Question 1. In the context of Mr. Johnson, the 62-year-old patient undergoing treatment for head and neck cancer has been scheduled for an external beam radiation therapy session. During his treatment planning session, his radiation oncologist discusses how radiation interacts with matter and the subsequent biological effects. Mr. Johnson is particularly concerned about the potential DNA damage induced by ionizing radiation and the implications for healthy tissue surrounding the tumor. The treatment team explains that when high-energy photons interact with biological tissues, they produce free radicals that can cause double-strand breaks in DNA, leading to cell death or mutagenesis if repair mechanisms fail. They further outline that the degree of damage is dependent on the radiation dose, the type of radiation, and the inherent radiosensitivity of the tissues involved. Based on current guidelines from the International Commission on Radiological Protection (ICOP) and the principles of radiation biology, which of the following statements best explains the primary mechanism by which radiation induces biological damage in tissues? A. Radiation predominantly causes biological damage through the generation of heat, which disrupts cellular structures. B. Radiation damages tissues by causing mechanical disruption of cell membranes without affecting the DNA. C. Radiation primarily induces biological damage through the production of free radicals, which leads to DNA double-strand breaks and subsequent cellular death. D. Radiation affects tissues by altering the chemical composition of cytoplasmic proteins. Answer. Correct answer, C. Explanation. Radiation interacts with biological tissues mainly through the ionization of molecules, leading to the formation of free radicals, particularly in water molecules that constitute a large part of cells. These free radicals are highly reactive and can induce significant damage by breaking the chemical bonds within DNA, particularly causing double-strand breaks. The body's repair mechanisms may be insufficient to fix such damage, resulting in cell death or mutations if errors occur during repair. This principle is foundational in radiation oncology, and guidelines such as those from the ICOP emphasize the importance of understanding these interactions to optimize treatment efficacy and minimize harm to normal tissues. The other options do not align with established radiobiological principles and misrepresent the mechanism of tissue injury during radio exposure. Question 2. According to recent studies, Ms. Thompson, a 48-year-old woman diagnosed with early-stage breast cancer, is undergoing simulation for a complex radiation treatment plan that requires meticulous calculation and measurement of the delivered dose. During the pre-treatment phase, her dosimetrist reviews several dose calculation algorithms to ensure the accurate quantification of dose distribution in the target tissue while sparing the critical structures such as the heart and lungs. In this scenario, the team emphasizes the importance of using dose volume histogram, D8, and Monte Carlo simulations to verify dose calculations. The clinical physicist explains that these methods are based on rigorous physics principles and ensure that uncertainties in dose measurement are minimized, which is crucial for both treatment efficacy and patient safety. With reference to the guide provided by the American Association of Physicists in Medicine (OPAM), which of the following statements best describes the optimal approach for dose calculation in this context? A. Relying solely on manual calculations and empirical estimations without computational verification. B. Using only simple algorithms that do not account for tissue heterogeneity. C. Ignoring DH analysis because it does not contribute to treatment optimization. D. Employing advanced computational methods such as Monte Carlo simulations combined with DH analysis to ensure accurate dose delivery and minimize uncertainties. Answer. Correct answer, D. Explanation. Advanced dose calculation methods, including Monte Carlo simulations and dose volume histogram DVH analysis, are essential tools in modern radiation oncology. These methods allow for a detailed understanding of how the radiation dose is distributed within the patient's anatomy, accounting for the complex interactions between radiation and various tissues. The OPAM guidelines underscore the importance using these advanced computational methods to optimize treatment planning, ensuring both tumor control and the minimization of dose to critical organs. This comprehensive approach helps mitigate uncertainties that could lead to suboptimal dosing or excessive exposure to healthy tissues. The other options neglect these vital elements and do not reflect current best practices in radiation dose calculation. Question 3. From the perspective of radiation oncology treatment planning, it is critical to understand the intricate concepts of dose distribution, dose homogeneity, and various dose delivery techniques. In a scenario where a patient is being considered for intensity-modulated radiation therapy for a complex pelvic tumor, the treatment planning team must ensure that the prescribed radiation dose is delivered uniformly across the tumor volume while sparing nearby organs at risk, or a failure in achieving dose homogeneity could lead to hotspots that risk toxicity or cold spots that may compromise tumor control. Modern treatment planning system (TPS) incorporates sophisticated algorithms to optimize beam configurations and modulate intensities, ensuring a fine balance between treatment efficacy and safety. According to the principles outlined in the Radiation Therapy Oncology Group (RTOG) protocols, which of the following best describes the objective in optimizing dose distribution during IMIP planning? A. Ensuring uniform dose distribution to the tumor while minimizing the dose to surrounding healthy tissues through modulation of beam intensities. B. Maximizing the total radiation dose irrespective of dose variations within the tumor and nearby structures. C. Delivering a concentrated dose to a small tumor volume without regard for adjacent normal tissues. D. Prioritizing dose delivery to the OR over the tumor to avoid potential side effects. Answer. Correct answer A. Explanation. The goal of IMIP planning is to achieve an optimal balance between delivering an effective dose to the tumor and protecting adjacent healthy tissues. This is accomplished through sophisticated computer algorithms that modulate beam intensities to ensure dose homogeneity across the tumor volume while minimizing exposure to organs at risk. Protocols such as those from RTOG provide detailed guidelines to help clinicians achieve these objectives, emphasizing the importance of dose conformity and uniformity to maximize tumor control probability (TCP) and reduce normal tissue complication probability (ATP). The other options either disregard the importance of homogeneity or mistakenly prioritize dose delivery in a manner that could compromise patient safety. These principles are fundamental in ensuring successful radiation therapy outcomes. Question 4. As illustrated by Dr. Garcia, a seasoned radiation oncologist at a tertiary care center, the advent of stereotactic radiosurgery (SRS) and stereotactic body radiation therapy (SRT) has revolutionized treatment options for patients with limited metastatic disease and small, well-defined tumors. In a recent case, a patient with a solitary brain metastases was considered for SRS due to its potential for precise dose delivery and minimal invasiveness compared to conventional surgery. Dr. Garcia emphasizes that the high precision of SRS requires rigorous quality assurance protocols and highly accurate imaging techniques to ensure that the steep dose gradients do not inadvertently damage surrounding critical brain structures. The treatment plan is developed using advanced computer-assisted planning systems that incorporate detailed anatomical data. In the context of these advanced radiotherapeutic techniques, which of the following statements best captures the critical factor for ensuring both the efficacy and safety of SRS? A. Relying solely on conventional imaging methods without the need for adaptive planning adjustments. B. Utilizing high-resolution imaging and strict quality assurance protocols to ensure precise dose delivery, with steep gradients minimizing exposure to adjacent critical structures. C. Administering a uniform high dose across a broad area regardless of target definition. D. Reducing treatment planning time at the expense of dose distribution analysis. Answer. Correct answer. B. Explanation. SRS SRT demand exceptional precision in both planning and delivery because they involve delivering very high doses in a limited number of fractions. High-resolution imaging is imperative to accurately delineate the target and surrounding critical structures, ensuring that the steep dose gradients do not compromise nearby healthy tissue. Quality assurance protocols are critical in verifying the act of the treatment plan and the integrity of the delivery system. The guidelines outlined by professional societies such as the American Society for Radiation Oncology (ASTRO) stress the necessity of rigorous co-adaptive planning to maintain the balance between maximizing tumor control and minimizing toxicity. Options A, C, and D neglect these essential elements, potentially compromising treatment outcomes and patient safety. Question 5. Based on the information, a radiation oncology team is tasked with developing a treatment plan for a patient with advanced lung cancer. In this scenario, the precision in delineating the tumor boundaries and sparing adjacent critical structures, particularly the heart and esophagus, is of paramount importance. The treatment plan involves creating detailed contours for both the gross tumor volume (GTV) and the organs at risk, or based on ET. MRI imaging. The team is guided by the principles of three-dimensional conformal radiation therapy (3DRT) and intensity-modulated radiation therapy (IMIT) to optimize the dose distribution. The aim is to achieve maximum tumor coverage while minimizing potential complications associated with excessive radiation exposure to OR. Considering the recommendations provided by the Radiation Therapy Oncology Group (RTOG) and relevant guidelines, which of the following approaches best aligns with the clinical goal of critical structure sparing in treatment planning? A. Ignoring all constraints in favor of maximizing tumor dose delivery. B. Utilizing a single beam approach to simplify the treatment plan regardless of OR proximity. C. Applying uniform radiation fields without individualized adjustments to anatomical variations. D. Integrating advanced imaging modalities and precise contouring techniques to ensure OR sparing while delivering an effective tumor dose. Answer. Correct answer, D. Explanation. Sparing critical structures while delivering an effective dose to the tumor is a central tenet of radiation oncology, particularly in complex cases such as lung cancer. The use of advanced imaging modalities such as ET and MRI allows for accurate delineation of both the target volumes and the adjacent organs at risk. By integrating these imaging techniques into three-dimensional treatment planning systems, clinicians can tailor beam arrangements and optimize dose distributions using methods like 3DRT and IMIT. This approach ensures that the tumor receives a sufficiently high dose for control while minimizing the exposure of critical structures, thereby reducing the risk of radiation-induced toxicity. The RTOG guidelines specifically stress the importance of individualized treatment planning, and the other options do not adequately address the need precise OR sparing. Question 6. With respect to Istali, a 55-year-old man with recurrent prostate cancer, his treatment team is evaluating the feasibility of proton therapy as a means to reduce radiation-induced toxicity while maintaining high tumor control rates. Proton therapy offers a unique advantage due to its Bragg peak phenomenon, which allows for maximal energy deposition at a precise depth with minimal exit dose, thereby sparing surrounding healthy tissues. Istali's case requires an in-depth analysis of tissue heterogeneity, target depth, and proximity to critical structures such as the rectum and bladder. The treatment planning involves sophisticated imaging and computational models to ensure accurate dose delivery, adhering to the principles outlined in the American Association of Physicists in Medicine (OPAM) guidelines for proton therapy. Given the clinical scenario and the technical advantages, proton therapy, which of the following statements best explains the rationale for selecting proton therapy in this case? A. Proton therapy is selected because it has higher overall energy output compared to conventional photon therapy, ensuring more aggressive tumor destruction. B. Proton therapy is chosen primarily for its cost-effectiveness and widespread availability in most treatment centers. C. Proton therapy is preferred due to its Bragg peak characteristic, which allows precise dose deposition within the tumor while minimizing exposure to surrounding normal tissues. D. Proton therapy is utilized because it eliminates the need for detailed treatment planning and imaging guidance. Answer. Correct answer, C. Explanation. Proton therapy is increasingly recognized for its unique dosimetric advantages, particularly the Bragg peak effect, which permits the delivery of high radiation doses directly to the tumor with minimal collateral damage to adjacent normal tissues. In Istali's case, where the tumor is situated near critical organs such as the rectum and bladder, proton therapy offers significant benefits in terms of reduced risk of radiation-induced toxicity. The precise dose deposition characteristic of proton therapy enables high level of conformity to the tumor shape, which is particularly advantageous for recurrent cancers that may have undergone previous treatments. Adhering to the OPAM guidelines, this approach requires detailed imaging and robust treatment planning to accurately map tissue heterogeneity and target depth. The other options either misinterpret advantages of proton therapy or ignore the critical planning processes involved. Question 7. Under the assumption that accurate dose calculations are pivotal to successful radiation treatment, consider A scenario where a radiation oncology team is developing a treatment plan for a patient with a gastrointestinal malignancy. The team must calculate the radiation dose using complex algorithms that account for tissue heterogeneity, scatter, and absorption. They rely on computational methods integrated into their treatment planning system, TPS, to ensure that the prescribed dose is delivered effectively to the tumor while reducing the risk of toxicity to nearby organs such as the liver and kidneys. The physicists involved in the process follow strict calibration protocols, including routine quality assurance procedures and equipment maintenance, as recommended by the American Association of Physicists in Medicine (OPAM). Which of the following best describes the primary reason for advanced dose calculation methods in this clinical context? A. To ensure that the complex interactions of radiation with heterogeneous tissues are accurately modeled, resulting in precise and safe dose delivery to the target, while minimizing exposure to normal tissues. B. To simplify the treatment planning process by disregarding tissue heterogeneity and assuming a uniform medium. C. To rely on historical dose data without incorporating real-time adjustments based on patient anatomy. To expedite treatment planning by using default dose calculation settings that do not require patient-specific modifications. Answer. Correct answer. A. Explanation. Accurate dose calculation is essential in radiation oncology to ensure that the therapeutic dose adequately covers the tumor while limiting exposure to surrounding healthy tissues. Advanced computational methods allow for precise modeling of the interactions between radiation and various tissue types, accounting for factors such as heterogeneity, scatter, and absorption. These methods, integrated into modern TPS, critical for delivering effective treatment and reducing the likelihood of toxicity. Following the rigorous protocols established by the OPAM, including routine calibration and quality assurance, further enhances treatment safety and efficacy. Simplified or default approaches, as in options B, C, and D, fail to capture the complexities of human anatomy and the physical interactions of radiation, which can compromise treatment outcomes. This deep modeling is particularly important in cases like gastrointestinal malignancies where multiple critical structures are involved. Question 8. Despite the fact that Isis Patel, a 70-year-old patient with head and neck cancer, is considered a high-risk candidate due to her comorbidities, the radiation oncology team must develop a treatment strategy that adheres to stringent radiation protection principles. In this scenario, the team faces the challenge of balancing the need for effective tumor control with the imperative to minimize radiation exposure to both the patient and the clinical staff. The department follows the ALARA as low as reasonably achievable principle, which is a cornerstone of radiation safety guidelines as recommended by regulatory bodies such as the Nuclear Regulatory Commission (NRC) and the International Commission on Radiological Protection (ICOP). The team is also required to implement comprehensive monitoring systems using radiation detectors and dosimeters to ensure continuous adherence to protocols. Which of the following strategies best encapsulates the essential principles of radiation protection in this clinical setting? A. Prioritizing patient treatment speed over radiation safety measures assuming minimal exposure risk. B. Strictly adhering to the ALARA principle by implementing rigorous monitoring protocols, protective barriers, and dose optimization techniques to ensure minimal radiation exposure for both the patient and clinical staff. C. Minimizing the use of protective equipment based on the assumption that modern equipment is inherently safe, relying on sporadic monitoring of radiation levels without a structured quality assurance program. Answer. Correct answer. B. Explanation. Radiation protection in the clinical setting is of paramount importance, particularly for high-risk patients like Isis Patel. The ALARA principle is a fundamental guideline ensuring that all radiation exposures are minimized as much as possible without compromising treatment efficacy. This involves a multifaceted approach that includes rigorous quality assurance, continuous monitoring with dosimeters, the protective barriers, and the optimization of treatment plans to reduce unnecessary exposure. Regulatory agencies such as the NRC and ICOP provide detailed guidelines that underscore the need for such comprehensive safety measures. By strictly adhering to these protocols, clinical teams can protect both patients and staff from the harmful effects of ionizing radiation. The other options either disregard these critical safety measures or do not implement the systematic approach required for effective radiation protection. Question 9. The general consensus is that ethical issues, including informed consent and patient autonomy, are fundamental in radiation oncology practice, especially when patients are faced with complex treatment decisions. In a case involving a 60-year-old patient with recurrent glioblastoma, the radiation oncology team is tasked with discussing the potential benefits and risks of an aggressive treatment protocol that may include a combination of conventional radiation therapy and experimental targeted agents. The patient's right to autonomy and informed consent is underscored by legal frameworks such as the Health Insurance Portability and Accountability (HIPAA) and the ethical guidelines established by the American Medical Association (AMA). The team must ensure that the patient is fully aware of the potential side effects, treatment uncertainties, and alternative options available, all while respecting their decision-making capacity. Which of the following best represents the ethical approach that should be adopted in obtaining informed consent in this scenario? A. Withholding detailed treatment information to prevent patient anxiety, thereby expediting the consent process. B. Presenting only the benefits of the treatment while minimizing discussion of potential risks. C. Relying on family members to make decisions without direct patient involvement, even if the patient is cognitively capable. D. Providing comprehensive, balanced information about the treatment options, including benefits, uncertainties, and alternatives, in compliance with HIPAA and AMA guidelines, thereby ensuring the patient's informed autonomy. Answer. Correct answer, D. Explanation. Informed consent is a critical ethical and legal requirement in the practice of radiation oncology. It ensures that patients like the 60-year-old with recurrent glioblastoma are fully informed about their treatment options, including potential risks, benefits, and alternatives. Legal frameworks such as HIPAA and ethical guidelines from the AMA mandate that patient autonomy is respected and that patients are provided with balanced, comprehensive information. This process involves clear communication of the uncertainties and potential outcomes associated with complex treatment protocols. The ethical approach is to engage the patient directly in the decision-making process, thereby enabling them to make choices that align with their values and preferences. Options A, B, and C either compromise the patient's right to full disclosure or exclude the patient from the decision-making process, both of which are inconsistent with accepted ethical practices. Question 10. In light of recent developments, Dr. Martinez, a leading radiation oncologist, is exploring the application of adaptive radiation therapy to personalize treatment for a patient with an advanced gastrointestinal tumor. The conventional treatment plan was initially based on pre-treatment imaging. However, significant anatomical changes were observed during the course of therapy due to tumor shrinkage and weight loss. ART enables clinicians to modify the treatment plan in real time by integrating periodic imaging feedback and adjusting the dose distribution accordingly. This strategy aims to maximize tumor control probability (TCP) while minimizing normal tissue complication probability (TP). The clinical team reviews the latest guidelines on adaptive planning from the American Society for Radiation Oncology (ASTRO) and considers implementation of AI-driven algorithms to further refine treatment personalization. Which of the following statements best encapsulates the primary benefit of adaptive radiation therapy in this scenario? A. Adaptive radiation therapy allows for the use of a static treatment plan regardless of anatomical changes, thereby simplifying treatment delivery. B. Adaptive radiation therapy eliminates the need for imaging feedback during the course of treatment, reducing overall complexity. C. Adaptive radiation therapy permits dynamic modifications of the treatment plan based on real-time anatomical changes, thereby optimizing dose delivery to the tumor while protecting normal tissues. D. Adaptive radiation therapy solely focuses on reducing treatment time without addressing changes in patient anatomy. Answer. Correct answer, C. Explanation. Adaptive radiation therapy represents a significant advancement in personalized cancer treatment. It enables clinicians to adjust the treatment plan in response to anatomical changes that occur during therapy, such as tumor shrinkage or patient weight loss. This dynamic approach, supported by regular imaging and increasingly by AI-driven algorithms, allows for real-time modifications that optimize those delivered to the tumor while concurrently protecting adjacent normal tissues. The guidelines from ASTRA highlight the importance of ART in improving treatment outcomes by enhancing tumor control probability (TCP) and reducing normal tissue complication probability (TEP). Unlike static plans that may become suboptimal as patient anatomy evolves, ART provides a tailored solution that addresses these changes effectively. The other do not capture the core benefit of art, which is its ability to adapt to ongoing physiological variations during the treatment course. Question 11. Given the circumstances, Dr. Smith is preparing to deliver radiation therapy to a patient with a brain tumor. He needs to ensure that the tumor receives the appropriate dose while sparing critical structures like the optic nerves and brainstem. What is the most important factor that Dr. Smith should consider in the treatment planning process? A. Ensuring the tumor receives the highest dose possible regardless of its impact on the surrounding tissues. B. Optimizing the dose distribution to deliver the prescribed dose to the tumor while minimizing dose to surrounding critical structures. C. Using only external beam radiation therapy (ABR) to treat the brain tumor. D. Focusing on using intensity modulated radiation therapy (IMR) only without considering other modalities. Answer. Correct answer. B. Optimizing the dose distribution to deliver the prescribed dose to the tumor while minimizing dose to surrounding critical structures. Explanation. In radiation therapy, particularly when treating tumors located near critical structures like the brainstem or optic nerves, it is essential to balance tumor dose coverage with normal tissue sparing. This is typically achieved through advanced treatment planning techniques such as intensity modulate, radiation therapy (IMRT), or volumetric modulated arc therapy (VMAT), which allow for precise dose delivery while minimizing exposure to surrounding healthy tissues. The principle of dose homogeneity and critical structure sparing plays a significant role in achieving optimal therapeutic outcomes with minimal side effects. Question 12. When analyzing a patient's treatment plan, Dr. Clark notices the dose of radiation is planned for the lungs and there are concerns about the risk of pneumonitis. What should Dr. Clark do to minimize the risk of this side effect? A. Increase the dose to the lungs to ensure tumor control. B. Use single radiation beam to focus the dose directly on the tumor. C. Optimize the treatment plan to reduce the lung dose while still adequately treating the tumor. D. Discontinue the radiation therapy and opt for chemotherapy alone. Answer. Correct answer. C. Optimize the treatment plan to reduce the lung dose while still adequately treating the tumor. Explanation. Pneumonitis is a potential side effect when irradiating the lungs, and it occurs due to inflammation and damage to lung tissue from radiation. To minimize this risk, Dr. Clark should focus on dose optimization using treatment planning techniques that ensure adequate tumor coverage while sparing as much lung tissue as possible. It be achieved through techniques such as IMRT, which allows for the modulation of radiation intensity, and by considering the dose volume constraints for organs at risk or like the lungs. The principle of minimizing exposure to healthy tissue is crucial in managing radiation side effects. Question 13. In terms of radiation therapy for a prostate cancer patient, Dr. Green needs to account for potential damage to surrounding organs like the bladder and rectum. What is the most effective method to minimize this risk during the planning phase? A. Use three-dimensional conformal radiation therapy (3DRT) to focus the dose on the prostate only. B. Optimize the treatment plan using dose constraints for the bladder and rectum while ensuring adequate dose to the prostate. C. Deliver the maximum dose to the prostate and allow any exposure to adjacent organs to occur. D. Use brachytherapy alone, disregarding the bladder and rectum. Answer. Correct answer. B. Optimize the treatment plan using dose constraints for the bladder and rectum while ensuring adequate dose to the prostate. Explanation. In prostate cancer treatment, minimizing radiation dose to organs such as the bladder and rectum is essential to reduce the risk of complications like incontinence or proctitis. The optimal approach is to use a treatment planning system (TPS) that incorporates dose constraints for these, while ensuring the prescribed dose reaches the prostate. Techniques like IMRT and VMAT can be particularly effective in this regard, as they provide high dose conformity to the target while minimizing dose to surrounding structures. This approach follows the concept of critical structure sparing in radiation oncology. Question 14. Based on the information provided, Mrs. Johnson, who is undergoing radiation therapy for breast cancer, expresses concerns about the potential long-term risks of radiation exposure, particularly the risk of secondary malignancies. What is the best approach to address her concerns? A. Ignore the concerns and reassure her that the benefits outweigh the risks of radiation. B. Discuss the potential risks of secondary malignancies, but focus on the effectiveness of the treatment. C. Explain that radiation therapy is designed to minimize the risk of secondary malignancies through careful planning and dosimetric techniques. D. Suggest that she postpone treatment to avoid any radiation exposure. Answer. Correct answer. C. Explain that radiation therapy is designed to minimize the risk of secondary malignancies through careful planning and dosimetric techniques. Explanation. Secondary malignancies are a potential long-term risk of radiation therapy, particularly for cancers like breast cancer. However, the risk can be minimized by using advanced treatment planning techniques, including IMA and dose optimization strategies that focus radiation precisely tumor while sparing surrounding healthy tissues. The ALARA, as low as reasonably achievable, principle in radiation protection also applies here, ensuring that the radiation dose to normal tissues is as low as possible while achieving the therapeutic goal. Clear communication about the precautions taken to mitigate these risks is important for patient understanding. Question 15. What factors should Octa-Lee consider when determining the gross tumor volume (GTV) for a patient undergoing radiation therapy for lung cancer? A. Only the visible tumor on the diagnostic imaging scans. B. The tumor size and surrounding healthy tissue affected by the tumor. C. The size of the tumor, adjacent lymph nodes, and any known metastases. D. Only the clinical tumor size, ignoring the effects on surrounding tissues. Answer. Correct answer. C. The size of the tumor, adjacent lymph nodes, and any known metastases. Explanation. The gross tumor volume (GTV) refers to the tumor's visible extent as determined by imaging studies such as ET-MRI. For lung cancer, the GTV is not limited to the primary tumor, but also includes any adjacent lymph nodes or known metastases that are involved in the disease process. This helps in accurately targeting the tumor during radiation therapy while ensuring that the entire tumor burden is treated. The next step involves defining the clinical target volume (ETV) and planning target volume (PTV) to account for microscopic disease and patient setup variations. Question 16. In what ways can Dr. Davis use adaptive radiation therapy (ART) to improve the accuracy of treatment delivery for a patient with a prostate tumor? A. By replanning the treatment weekly based on changes in the prostate's position. B. By delivering a uniform radiation dose over the entire prostate, regardless of changes in its position. C. By using ART to adjust the radiation dose only when the tumor has become larger. D. By not considering any adjustments to the treatment plan once the initial plan is finalized. Answer. Correct answer A. By replanning the treatment weekly based on changes in the prostate's position. Explanation. Adaptive radiation therapy involves adjusting the treatment plan based on anatomical changes during the course of treatment. For a prostate cancer patient, ART can account for variations in the prostate's position due to bladder filling, bowel movement, or other factors. This approach ensures that the tumor receives the prescribed dose while minimizing exposure to surrounding tissues like the bladder and rectum. Weekly replanning is a common strategy to adapt the treatment to these changes, optimizing treatment efficacy and minimizing side effects. Question 17. Under the assumption that a patient is undergoing treatment for a lung tumor, which of the following factors would most likely contribute to a poor tumor control probability (TCP)? A. A highly conformal treatment plan with accurate dose distribution. B. Significant movement of the tumor during respiration that is not accounted for in the treatment plan. C. The use of radioprotectors to enhance normal tissue resistance. D. Delivery of the highest possible radiation dose to the tumor. Answer. Correct answer. B. Significant movement of the tumor during respiration that is not accounted for in the treatment plan. Explanation. Tumor movement due to respiration, particularly for lung tumors, is a critical challenge in radiation therapy. If the movement is not accounted for in the treatment planning process, it can result in underdosing the tumor or irradiating healthy tissues. This decreases the tumor control probability (TCP). Strategies: respiratory gating, forward CT imaging, or intensity-modulated radiation therapy (IMAD) can help manage tumor motion and ensure accurate dose delivery to the target. Addressing tumor movement is crucial for optimizing the effectiveness of radiation therapy. Question 18. When considering the potential for radiation-induced toxicity in a patient undergoing brain radiation, Dr. Patel should focus primarily on A. The potential damage to normal brain tissue and structures such as the hippocampus. B. The risk of visual complications due to radiation exposure to the eyes. C. The tumor's response to radiation without concern for surrounding normal tissues. D. The development of radiation dermatitis in the skin due to external beam radiation. Answer. Correct answer A. The potential damage to normal brain tissue and structures such as the hippocampus. Explanation. When irradiating brain tumors, special attention must be given to minimizing the dose to normal brain tissues, including the hippocampus, which is critical for memory and cognitive function. Radiation-induced toxicity can lead to long-term side effects such as cognitive decline, so the goal is to deliver the prescribed dose to the tumor, sparing as much healthy tissue as possible. Techniques like IMET, which offers precise dose modulation, are essential for reducing the risk of such toxicities. Question 19. Which of the following is most essential for ensuring the accuracy of radiation therapy delivery in a patient with a tumor located near critical structures, such as the spine? A. Using a single radiation beam to target the tumor precisely. B. Incorporating patient positioning accuracy and imaging to verify tumor location before each treatment. C. Focusing solely on the tumor without considering its proximity to other structures. D. Delivering a higher dose to compensate for the proximity of critical structures. Answer. Correct answer. B. Incorporating patient positioning accuracy and imaging to verify tumor location before each treatment. Explanation. The accuracy of radiation therapy delivery is crucial when treating tumors located near critical structures, such as the spine. Ensuring that the tumor is accurately targeted and that the treatment is delivered precisely requires the use of patient positioning techniques, e.g. immobilization devices, and free imaging, e.g. CertMedbry, to verify tumor location before each session. This process, known as image-guided radiation therapy, ensures that the tumor is irradiated accurately while minimizing the risk of damage to surrounding healthy tissues. Question 20. Dr. Williams is considering using high-dose rate HDR brachytherapy for a prostate cancer patient. Which of the following benefits is most associated with HDR brachytherapy compared to low-dose rate LDR brachytherapy? A. The ability to deliver a higher total dose in a shorter period while minimizing exposure to surrounding tissues. B. The need for longer treatment durations, leading to fewer sessions for the patient. C. The decreased risk of tumor control due to the lower dose per fraction. D. The increased risk of side effects due to prolonged radiation exposure. Answer. Correct answer A. The ability to deliver a higher total dose in a shorter period while minimizing exposure to surrounding tissues. Explanation. High-dose RET HDR brachytherapy allows for the delivery of a high radiation dose over a shorter period compared to low-dose rate LDR brachytherapy. This technique is beneficial because it can deliver a high dose to the tumor while minimizing radiation exposure to surrounding healthy tissues. HD brachytherapy typically requires fewer treatment sessions and is more adaptable to precise tumor targeting, making it a preferred choice in certain clinical situations. This precision helps reduce the risk of side effects and improves treatment outcomes. Question 21. Under the assumption that advanced treatment modalities can significantly improve therapeutic outcomes, Dr. Rodriguez is planning proton therapy for a 54-year-old patient with oropharyngeal carcinoma. The tumor is located in a region densely populated by critical structures, including the spinal cord and salivary glands, making precise dose deposition paramount. Given the anatomical complexity and the potential for variations due to swallowing, weight loss, or slight positional changes, the team incorporates robust optimization in treatment planning. Daily imaging verification and Monte Carlo simulations are employed to predict dose deposition accurately, particularly harnessing the unique Bragg peak of proton therapy. This approach aims to deliver a high dose directly to the tumor while sparing the adjacent healthy tissues from unnecessary exposure. Based Open guidelines for proton therapy. Which of the following best justifies the selection of proton therapy in this scenario? A. Proton therapy is used because it provides a uniform dose distribution that is independent of tissue heterogeneity. B. Proton therapy is selected due to its ability to reduce treatment times by using lower energy beams. C. Proton therapy is chosen because it offers similar outcomes to photon therapy but with simpler planning requirements. D. Proton therapy utilizes the Bragg peak phenomenon to deliver a concentrated dose to the tumor while minimizing dose to surrounding critical structures, thereby reducing potential side effects. Answer. Correct answer D. Explanation. Proton therapy's key advantage is the Bragg peak phenomenon, which allows the majority of the proton's energy to be deposited at specific depth, precisely where the tumor is located. This minimizes the exit dose and spares surrounding healthy tissues. In the case of oropharyngeal carcinoma near critical structures, robust treatment planning, daily imaging, and Monte Carlo simulations are essential to account anatomical variations. The American Association of Physicists in Medicine (OPAM) guidelines emphasize that such precision is critical for reducing toxicity and improving outcomes in complex anatomical regions. Options A, B, and C misrepresent the technical advantages and planning requirements of proton therapy. Question 22. When analyzing a complex case of early-stage lung cancer, Dr. Adams is tasked with managing a small peripheral lesion using stereotactic body radiation therapy (SRT). The patient's tumor exhibits considerable motion due to respiration, which poses significant challenges for ensuring accurate dose delivery. To address this, the clinical team has integrated forward CT imaging and respiratory gating into the treatment workflow. These allow for the synchronization of radiation delivery with the patient's breathing cycle, thereby reducing the risk of geographic miss and ensuring that the tumor consistently receives the prescribed dose. Additionally, the treatment plan is regularly reviewed and adjusted based on motion studies and interfraction variability, according to recent ASTRA recommendations on managing respiratory motion in LA-SRT. Which of the following measures is most critical? Ensure accurate treatment. A. Relying solely on conventional CT imaging without any respiratory motion management. B. Incorporating respiratory gating and forward imaging to account for tumor motion and ensure precise dose delivery. C. Using higher static dose to compensate for any motion-induced uncertainties during treatment. D. Applying uniform treatment plan without adjustments for respiratory motion throughout the treatment course. Answer. Correct answer B. Explanation. Managing respiratory motion is essential for accurately targeting lung tumors with SRT. The integration of forward CT imaging and respiratory gating techniques ensures that the tumor's motion is accounted for during dose delivery. This approach minimizes the risk of underdosing the tumor or overdosing healthy lung tissue. ASTRA guidelines strongly recommend these advanced imaging and gating strategies to improve treatment accuracy and reduce complications. Options A, C, and D either ignore motion management or suggest compensatory measures that do not address the root cause of the variability, thereby compromising treatment precision. Question 23. From the perspective of high-precision brachytherapy, Dr. Lee is managing a 63-year-old patient with intermediate-risk prostate cancer scheduled for high-dose red HDR brachytherapy. Given the close proximity of the prostate to the urethra and rectum, the radiation oncologist is particularly concerned about minimizing toxicity while ensuring sufficient tumor coverage. The treatment planning team uses advanced imaging to guide catheter place and optimize dwell positions for the radioactive source. They also integrate real-time dosimetric verification to monitor dose distribution within the prostate and adjacent critical structures. The clinical goal is to maximize tumor control while mitigating the risk of urethral injury and rectal toxicity. In light of these considerations and following guidelines from the American Brachytherapy Society, which of the following strategies minimizes the risk of urethral toxicity? A. Increasing the overall treatment dose to overcome potential dosimetric uncertainties. B. Relying solely on pre-planned catheter placement without intraoperative imaging verification. C. Optimizing catheter placement and dwell time planning to reduce the dose to the urethra while ensuring adequate prostate coverage. D. Using low-dose rate brachytherapy exclusively to reduce acute toxicity risks. Answer. Correct answer C. Explanation. HDR brachytherapy allows for precise modulation of dose delivery by adjusting catheter placement and dwell times. By optimizing these parameters, the radiation dose can be concentrated within the prostate while sparing the urethra and rectum from excessive exposure. The American Brachytherapy Society guidelines emphasize the importance of image guidance and real-time dosimetry to achieve these goals. Options A and B may increase toxicity risk, while D does not specifically address the dosimetric precision required for minimizing urethral dose in HDR brachytherapy. Question 24. Based on the information, Dr. Kim is treating a 47-year-old patient with nasopharyngeal carcinoma using intensity-modulated radiation therapy (IMIT). Given the tumor's location near critical structures such as the brainstem and optic apparatus, the treatment team is using adaptive planning to adjust for daily anatomical variations. The patient's anatomy is re-imaged frequently to account for changes due to weight loss and to regression, ensuring that the dose conforms closely to the target while sparing the adjacent normal tissues. The clinical challenge is to maintain high tumor control probability (TCP) without inducing significant neurotoxicity. Which of the following approaches best addresses this challenge? A. Implementing adaptive IMIT planning that incorporates daily image guidance and dosimetric adjustments to account for anatomical changes. B. Utilizing single, static IMIT plan developed at the start of treatment regardless of anatomical changes. C. Increasing the margin around the target volume to compensate for potential anatomical variations. D. Relying solely on conventional external beam radiation therapy techniques with adaptive planning. Answer. Correct answer A. Explanation. Adaptive IMIT planning is a key strategy to manage the dynamic anatomical changes that can occur during the treatment course, particularly in head and neck cancers. Daily image guidance allows for real-time adjustments, ensuring that the prescribed dose continues to conform to the tumor while protecting adjacent critical structures. This approach is in line with ASTRA recommendations and the principles of precision medicine. Radiation oncology. Options B, C, and D do not adequately account for the daily variations in anatomy and may lead to suboptimal tumor coverage or increased toxicity. Question 25. When considering a case of locally advanced lung cancer in MS, Nguyen, the treatment planning team is using intensity-modulated radiation therapy (IMIT) to achieve optimal dose distribution. Given the radiosensitivity of lung tissue and the risk of radiation-induced pneumonitis, meticulous adherence to dose-volume constraints is critical. The planning process involves detailed dose-volume histogram DVH analysis and robust optimization to ensure that the volume of lung receiving high doses is minimized while achieving adequate tumor coverage. The clinical team continuously reviews dosimetric parameters against established guidelines to balance treatment efficacy with the risk of pulmonary toxicity. Which of the following strategies best aligns with current recommendations to minimize radiation-induced lung toxicity? A. Ignoring DH constraints to maximize the overall dose delivered to the tumor. B. Utilizing advanced planning techniques such as IMIT along with DH analysis to ensure lung dose is minimized while achieving adequate tumor coverage. C. Increasing the treatment margins around the tumor irrespective of the dose received by the normal lung tissue. D. Relying solely on conventional two-dimensional planning methods without dose-volume analysis. Answer. Correct answer B. Explanation. Minimizing lung toxicity is paramount in treating lung cancer. Advanced planning techniques like IMIT, combined with detailed DEH analysis, allow clinicians to optimize the dose distribution so that critical lung volumes receive minimal exposure. This approach adheres to established guidelines from the Radiation Therapy Oncology Group. RTOG and is crucial for reducing the risk of radiation-induced pneumonia while ensuring effective tumor control. Options A, C, and D do not effectively address the balance between tumor dosing and lung tissue sparing. Question 26. With respect to maintaining a safe clinical environment, Dr. Patel is reviewing radiation safety protocols at a busy oncology center. The goal is to minimize staff exposure to ionizing radiation while ensuring that patients receive the optimal therapeutic dose. Given the potential hazards associated with scatter radiation and leakage from treatment machines, the center is implementing strict radiation monitoring and protection measures. These include the use of personal dosimeters, the installation of protective shielding in treatment rooms, and routine quality assurance of equipment. The clinical leadership is committed to adhering to the ALARA as low as reasonably achievable principle and relevant NRC guidelines. Which of the following strategies best embodies the ALARA principle for staff radiation protection? A. Allowing occasional unmonitored exposures if the overall exposure remains below regulatory limits. B. Minimizing protective measures because modern equipment is designed to be inherently safe. C. Implementing strict radiation monitoring protocols, utilizing protective shielding and dosimeters, and ensuring routine equipment care to minimize staff exposure. D. Focusing on patient safety alone while assuming staff exposures are negligible. Answer. Correct answer. C. Explanation. The ALARA principle mandates that all possible measures be taken to minimize radiation exposure. This includes using personal dosimeters, installing protective barriers, and performing routine car checks to ensure equipment operates within safe parameters. These strategies not only protect staff but also help maintain a safe environment for patients. Regulatory bodies such as the NRC emphasize the importance of these measures to minimize occupational exposure. Options A, B, and D either downplay the importance of comprehensive radiation safety protocols or fail to address the multifaceted nature of radiation protection. Question 27. Throughout the course of treatment for a patient with a gastrointestinal tumor, Dr. Johnson is utilizing three-dimensional 3D treatment planning to delineate target volumes and critical structures accurately. As treatment progresses, the patient exhibits significant anatomical changes, such as tumor shrinkage and weight loss, which could affect the accuracy of the initial plan. In response, the clinical team is considering adaptive radiation therapy to modify the treatment plan in real time. ART involves re-imaging the patient and recalculating dose distributions to ensure continued target coverage and organ at risk or sparing. This dynamic approach is supported by guidelines from ASTRO, which emphasize the benefits of adaptive strategies in managing anatomical variations. Which of the following best explains the importance of adaptive radiation therapy in this clinical context? A. It allows for a static treatment plan to be applied uniformly throughout the treatment course. B. It permits the use of larger margins around the tumor without the need for replanning. C. It eliminates the need for routine imaging during treatment. D. It allows for modifications of the treatment plan based on ongoing imaging feedback, thereby accommodating anatomical changes and ensuring optimal dose delivery to the tumor whilst normal tissues. Answer. Correct answer. D. Explanation. Adaptive radiation therapy is critical when significant anatomical changes occur during treatment, as it allows for real-time modifications of the treatment plan. This approach ensures that the target volume continues to receive the prescribed dose while minimizing exposure to normal tissues. ASTRO guidelines support ART as a means to improve tumor control probability (TCP) and reduce normal tissue complication probability (TEP). Options A, B, and C fail to address the need for dynamic adjustments based on the patient's evolving anatomy. Question 20. Considering the evidence, Dr. Garcia is tasked with designing a fractionation schedule for a 35-year-old patient with a low-grade glioma located in a sensitive brain region. The treatment team must balance the benefits of a higher per fraction dose to enhance tumor control with the risk of neurotoxicity, particularly in regions associated with cognitive function such as the hippocampus. Detailed discussions among the neuro-oncology emphasize the importance of fraction size, total dose, and treatment duration. The goal is to maximize tumor control while preserving normal brain function. Based on current radiobiological principles and ASTRO guidelines, which of the following fractionation strategies best balances these competing concerns? A. Using a hyperfractionated schedule with carefully calibrated doses per fraction to maximize tumor control while minimizing cumulative dose to normal brain tissue. B. Administering a single large dose of radiation to the entire affected area. C. Utilizing hyperfractionation with very small doses delivered multiple times per day without consideration of total treatment time. D. Relying on conventional fractionation without adjustments for the sensitivity of surrounding normal tissues. Answer. Correct answer. A. Explanation. Hypofractionated schedules can be advantageous when carefully calibrated, as they deliver a higher dose per fraction over fewer sessions, potentially increasing tumor control while limiting overall exposure to sensitive brain regions. This approach, when executed with precision, minimizes the risk of cumulative neurotoxicity. Guidelines from astro and radiobiological principles support the careful balance between effective tumor dosing and preservation of normal tissue function. Options B, C, and D either expose the patient to higher toxicity risks or do not provide the necessary dose conformity to sensitive structures. Question 29. In the context of reirradiation for recurrent head and neck cancer, Dr. Evans is evaluating a 68-year-old patient who previously received definitive radiation therapy. The patient now presents with a localized recurrence in an area that has already been exposed to high doses of radiation. The clinical challenge is to achieve tumor control while minimizing the risk of cumulative toxicity to previously irradiated tissues. The treatment planning team employs advanced imaging, dosimetric analysis, and adaptive planning techniques to carefully map prior dose distributions. They also incorporate normal tissue tolerance data from previous treatments to guide the reirradiation strategy. Which of the following approaches best minimizes the risk of severe toxicity during reirradiation? A. Administering the same radiation dose as in the initial treatment regardless of previous exposure. B. Utilizing advanced imaging and adaptive planning techniques to carefully map prior dose distributions and ensure critical structures are spared in the new treatment plan. C. Increasing the overall dose to overcome the radioresistant nature of recurrent tumors without adjusting for previous exposure. D. Abandoning reirradiation in favor of systemic therapy without attempting localized treatment. Answer. Correct answer. B. Explanation. Reirradiation requires meticulous planning to avoid excessive cumulative doses to normal tissues. Advanced imaging and adaptive planning techniques allow the team to accurately account for prior radiation exposure and adjust the new treatment plan accordingly. This strategy helps maintain tumor control while reducing the risk of severe toxicity. Guidelines from professional societies emphasize the importance of considering previous dose distributions and normal tissue tolerances during reirradiation. Options A, C, and D either disregard prior exposure or opt out of potentially beneficial localized treatment. Question 30. In a modern context of particle therapy for pediatric oncology, Dr. Wong is evaluating a 10-year-old patient diagnosed with a low-grade brain tumor. Given the patient's young age and the long-term risks associated with radiation exposure, the treatment team is considering heavy ion therapy as means to optimize tumor control while minimizing late effects on the developing brain. Heavy ion therapy is known for its superior conformity and higher relative biological effectiveness RB compared to conventional photon therapy. This approach allows for more precise delivery of radiation, sparing critical neural structures and reducing the risk of long-term cognitive deficits. Which of the following statements best describes the advantage of heavy ion therapy in this pediatric case? A. Heavy ion therapy is preferred because it requires less complex treatment planning than photon therapy. B. Heavy ion therapy is advantageous because it uses lower doses overall, eliminating the need for detailed dosimetric calculations. C. Heavy ion therapy offers improved dose conformity and higher relative biological effectiveness. RB, which is particularly beneficial in pediatric cases to maximize tumor control, reducing long-term side effects on developing tissues. D. Heavy ion therapy is selected because it completely eliminates radiation exposure to normal tissues, ensuring zero risk of late effects. Answer. Correct answer. C. Explanation. Heavy ion therapy offers significant advantages in pediatric oncology due to its superior dose distribution and higher RB. This allows for a highly conformal dose to be delivered to the tumor while sparing surrounding healthy tissues, which is critical in children whose developing tissues are more sensitive to radiation. The precision of heavy ion therapy reduces the likelihood of long-term side effects, such as cognitive deficits, making it a preferred choice in pediatric cases. Although treatment planning is complex, the clinical benefits in terms of reduced late toxicity are well supported by current research and guidelines. Options A, B, and D do not accurately reflect the technical and clinical realities of heavy ion therapy.